Joining us now is Dr. Nicole Vermans and Dr. Sheila Riazi for the session Strength Within Limits Exercise Options for R-Wire 1RD, and also Dr. Meenal Jain. They are all on our scientific advisory board. Dr. Jain is a research physical therapist at the National Institutes of Health Clinical Center with extensive experience in neuromuscular diseases, focusing on motor assessments and innovative technologies like wearable sensors to measure motor changes. Do you each want a microphone? Is there like a what the answer? I don't know who wants to be in charge.
I'll be in charge of it again. You're an official in charge. Oh, I'm in charge.
Oh, no, that's lucky. All right.
Hello, everybody. Everybody ready for exercise? Yes. Okay, I'm at a bad because I can't see because of my height. There we go. There we go. I can see that. So welcome, everybody. This is our shared presentation with Dr. Vorman and Dr. Riazi on exercise. And as you all may know, there's a very different ways of approaching exercise. So we will try to give you some practical advice in terms of what works best. And I will try to advance. There we go. So here we are. We'll just go through. So we wanted to kind of talk about the clinical care guidelines. Dr. Riazi, did you want to start? Because these are your slides. So, did you want to present?
I think they're mine. Yes.
Are they yours? Okay.
We prepared
Okay,
many
sorry.
presentations, so we got lost track a little bit of what we prepared. I think I started out with these, but looking at what the clinical care guidelines on the website of the foundation recommend, and that's regular aerobic exercise 2 to 3 times per week, and that's in line with the recommendations of the World Health Organization. And it seems very down to earth, but if I ask my patients in my clinic, or if I ask myself at the end of the week, did I do this, then I can't be positive every week, unfortunately. And it's something you have to be aware of. I think that many of us have a profession in which we sit, or we are studying in a direction in which we sit a lot, and being physically active is not the default anymore. So I was just talking to one of the people in the room saying, well, try to include physical activity in your daily life as part of your daily routine. And of course, physical activity is different if you're wheelchair dependent, if you have proximal muscle weakness, but there are very many ways in which you can be physically active, and this is the general recommendation for that. Do you want to add anything on that?
Yeah. So, so as Dr. Vorman said, that it is really important to include. And this is a cumulative effect in terms of cumulative. There's now a growing body of evidence in activity and physical activity is to do micro breaks. So just like there's been a change in the way you eat, you do 6 meals a day, a little snack. So they talk about exercise snacks. So if it is a matter of just getting up to move, to go to the copier to get something, or getting up to, rather than sending an email or a Slack message to your colleague, just walk over to their desk. Well, in this environment of work from home, that's not possible. But and if you are limited in your mobility, there are other ways to do that as well too. It's just putting things down, lifting your arms up in the air to reach for things. So there's other ways of managing your mobility, and it's really important to continue doing these at least 150 to 300 minutes a week, which I know I don't. So the way that I have done this is by having people follow and track their activity using their smartwatch if they have one, and even for people who are in a chair. And I say this more because of I have seen my mom who is limited mobility. She wears her Fitbit on her wrist, and I'll come home and she's like, I did 1,000 steps today. And I'm like, well, what did you do? Well, I was helping to cook or do whatever. So even in people who are moving with limited mobility, walking, you can still engage in doing some type of upper extremity movement, and it'll get tracked on your Fitbit poorly, but it will still do it. So, all right, so we're just gonna go through this. So we've talked about in terms of, again, I'm gonna, okay. We did this it's a shared, so it's kind of, so it's not only important just for your physical activity in terms of your heart, your lungs, but it's also in terms of your mental health. It gives you a break from doing whatever you need to do, and you can find an activity that's important to you, whether it's just walking, swimming, dancing, anything that you can do on a consistent basis that you know that you can do. So there was a saying, I can't remember who said this, but sitting is the new smoking. So smoking kills and sitting kills, so it's important. So if you're in a chair, it is really important for you to be able to get in and out of the chair, and that is what the role of a physical therapist is to help you figure out how to do that as much as possible, as practically as possible, so that you can get some activity going in that way. Okay. We're just going to... Those are some guidelines that are the World Health Organization. So again, suggested forms of activity could be these simple things: swimming, walking, running, cycling, dancing, gardening. Those are simple things, and you could do it alone, you could do it with somebody else. And the idea is just to keep moving.
And it should also be affordable and accessible.
Correct.
Near where you're living. And it can also mean that you park your car further away, at one parking spot further away, so you walk a little bit further. So it can be in all little things throughout the day.
Right. Micro breaks, as they say. All right.
Thank you. We did some studies to understand basically a bit of a pathophysiology behind these patients' exercise tolerance. And what we found out, we did, we call it the in vivo, so we took the patient into the MR spectroscopy, and we, with the help of an exercise physiologist, we made them do certain, workouts, and we measured aerobic metabolism, anaerobic metabolism, and we found out that actually patients with RYR1 and MHS, they have issues, or they impaired basically aerobic metabolism. So normally whenever you exercise, the first couple of minutes, say you run, the first couple of minutes are anaerobe, and then you should switch to, your body switches to aerobic metabolism. And then depending on your stamina, your endurance, at some point that aerobic switches to anaerobe. In patients with ROR1 conditions with MHS, that aerobic metabolism, that aerobic phase actually is very shortened. So they keep using their anaerobe, which is an inefficient way of making, ATP, the energy bundle, and that's why you get, patients get a lot of muscle pain and all that, because you produce a lot of lactate. And when we measure this ATP production through the anaerobe pathway, we noticed in that second, the graph, which was, the graph on the right, it's Wingate test, which basically shows when you reach the fatigue. It showed that the lower ATP production that you get through the, defective metabolism, the higher fatigue that you get through the Wingate test.
So I want to piggyback on what Dr. Riazi said. So we did the NAC trial, and one of the outcome measures that we used at the NAC trial was an exercise test. And we measured individuals while they were cycling to their maximum. And we found, and then we tested them at 0 months, and then 6 months later, and then after they did the NAC, which I'm not able to share the results right now. And these results are being published right now as we talk about it. But what we did see was that people with RYR1 had a lower, their VO2 max after exercising was lower than the normal population, the typical population. But the other thing that was positive is that 6 months later, we saw that it was about the same. So it hadn't progressed, and it was showing that it's disease stable. But now we're going to look at the results and analyze it after the NAC to see if there's been any change. So this is being studied, not just in Dr. Riazi's lab, but also in terms of exercise for other further studies too. Okay. So the most important thing that we know about, and this has been talked about extensively here, is in terms of being aware of rhabdomyolysis, and then heat insensitivity. So you want to make sure that you exercise, but these are the things that you should not be doing. And when we talk about resistance training, we're talking about you don't want to use like a lot of eccentric muscle contraction. You want to be very slow and measured in your when you're strengthening. There are ways to build your exercise program in such a way that it is safe to do, and you should be working with a physical therapist who knows about this RYR1 or any kind of muscular dystrophies to be able to build a proper exercise program for you. We don't recommend HIIT training, so all of these things are kind of, we don't encourage them, so. All right, so again, too much, too fast. There's been a lot of studies out there that says that if you try to exercise to your maximum, and we've heard story about, Cody's been talking about it, so you have to be really careful in terms of how much you're doing. And this is for the people who are minimally affected. So they're the ones that think like, oh, I can kind of do this, but they really need to be careful and mindful of what they're able to do and their abilities. So to be careful. All right. So are there some people with RYR1 who should not exercise? So first and foremost, speak to your physician and then your physical therapist if you have one. If you don't, then please ask to be referred to a physical therapist. In other countries, I don't know if it's a direct referral or not. There is always a way to exercise, incorporate exercise, no matter what your abilities are. And if you have a physical therapist who is knowledgeable, they will find a way. And if they can't find a way for you, you need to find another physical therapist. That's pretty much it. And then the other point is that anyone can exercise safely, anyone. And when as a PT, and when I talk about exercise, it doesn't have to be 30 minutes, 4 times a week. It can be broken up into a couple of like little sessions, as I keep talking about. And anybody can do anything. And there's been I had another patient who would like just transfer from their chair to their bed, back to the chair, back to the bed. So that in itself was doing a lot of activity for that. So even that could be considered exercise. So don't let anybody say, oh, what you're doing, that's not exercise. That's not true. Any kind of movement is very important. Okay?
I don't recommend creatinine, but some people ask me about it, and it's generally safe, but it has not been studied in individuals with RYR1 related myopathies or malignant hyperthermia susceptibility in particular. And protein is considered to be safe, but also has not been studied. And what we do know, and what is recommended, but that's for the general population, is vitamin D. For bone health, and if there's not sufficient calcium intake in the nutrition, you can supplement it with calcium tablets. That's what you can discuss with the general practitioner or dietitian. Vitamin D and calcium is important for bone strength. And bone strength is important to prevent fractures. And if you prevent fractures, you prevent yourself for being in a situation at an older age where you are immobilized for 6 or 8 weeks, which really causes a lot of muscle loss. And I think you want to say something about it?
Yeah. So so one of the, as a pediatric physical therapist, one of the most important things that I tell all of my patients and everybody is the most important task is to be upright and walking in any way possible. So whether it's using AFOs, a walker, a gait trainer, or any other mobility aid, that is the most important thing, because even though I don't have research to support that it helps with 3 main goals. One is bone health. We do have research to show that weight bearing helps improve bone health. But the other 2 items that I don't know if there's enough research out there, but I know anecdotally it helps with lung health, because you're upright, you're sitting, you're not upright and standing, and you're able to move. And then the other one is bowel and bladder health. Just think about how, like, if you're sitting all the time, it does affect your bowel and bladder. So when you're upright and standing, gravity will help you. So those are the 3 main reasons that I really, really push for people to be upright and standing in any way possible for as long as possible, feasibly. We don't want to be unsafe. So that's really, really important. And in clinics, I don't know about other clinics across other countries, but we do now, at least in the US, we have body weight supported devices, and there are at-home devices. They're expensive, and sometimes they're not, they just take up too much space. But in our clinic, we have the body weight supported, and we get everybody up and standing. There are standing frames for kids. There's many other upright mobility devices.
Yeah, and in the graph, we didn't talk about it yet, but you see the line depicting how bone strength goes up in growing up, and then comes to a maximum, and then goes down. And after menopause, in females, it goes down more rapidly. And here's the difference between the individuals in the room who have malignant hyperthermia susceptibility and have been doing a lot of sports, because they will be on a high line for bone strength, whereas children with congenital myopathies who were never able to run or jump did not get the ability in life to build strong bones and might be at a higher risk for low bone strength at a later age and have fractures. And anything to comment on it? But that's what you see on the figure on the left of the slide.
Yeah, no, to add to what you're saying is that it is important to be upright and standing. So what we are doing is, and what generally is, we try to have the kids upright and standing at least by 2 years of age through any means possible, standing frame, walker, any kind of thing, because 2 years is also kind of the age that most children are upright, and typically developing children. And they're not only is it for bone strength, but also for cognitive and for socialization. It's hard to socialize when you're sitting and you're sitting in a chair. It's hard. So if you're upright and people can see you, then you'll be able to interact with everybody. So it's also for that reason too, not just for the physiological. Okay. All right. So exercise prescription management, you want to choose a PT. So in the US, there are 2 types of trained physical therapists who are board certified that you would want to look for if you can. One is a neurologically certified specialist, and then the other one is a pediatric certified specialist, but that doesn't mean you can't go to your local PT. Make sure you just ask them these specific questions, and have you worked with anybody with a neuromuscular disorder? And if not, do you have the resources to find out more about my condition? But in today's day of AI and Chat GPT and all that, I'm sure you can, a therapist can do that, but still you want to make sure that the therapist that you work with is in tune to that. One of the biggest things that you don't want to do is you don't want to be with a therapist who will say no pain, no gain. As a profession, we are kind of moving away from that. I don't want us to be talking about that. If you have a therapist who will not listen to your complaints about it's hurting, then again, find a new PT if you can.
And it does not always have to be someone who's very experienced. I recommend my patients see if someone is listening to you and eager to learn about your condition, provide information. If you see that someone is wanting to learn, and ask or call more experienced physical therapist for advice, that's a positive thing.
The other thing that we didn't talk about, that we always need to talk about when we're talking about RYR1, is in terms of environmental conditions. But again, as these two have alluded to, in terms of the heat intolerance. So you want to make sure you avoid extremes, heat and cold. And there, I've been talking to some of the people here, and it's just a change in temperature, and the water temperature when they're swimming can make a big difference, or outside. So just be mindful of where you're exercising, and be able to make sure that you are in a comfortable environmental condition. Also, if possible, you want to make sure to take your temperature before you exercise, just to kind of make sure that you're not stressing yourself out. So.
Another aspect to consider is for the patients who have a myopathy and have less muscle volume, they also have less heating in their body, because the muscles are very inefficient where it's about moving. They produce a lot of heat. And if you have a myopathy, you will probably know that it's very easy to get cold, and it takes a long time to warm up again. So if you would be outside, like the photograph you see on down of the slide, make sure you're pre-warmed sufficiently and you're packed sufficiently. So wear warm clothes where someone else would not have to do that with that temperature. Prevention of cooling down is better than trying to reheat afterwards.
So we used to live in a land with large malls, but those malls have gone away, because a lot of malls used to open up their there are spaces for people to walk for exercise, and it used to be with the American Heart Association. No, it was a collaborative.
No, we don't have big malls in
you
the
don't have
Netherlands.
big malls, yeah. So in lieu of big malls, Costco, Walmart, those are great big spaces. Those are places that you can go. The danger is you don't want to stop and get the samples, whatever. But so again, it's the it's the physical therapist who can help you find ways to exercise in a more efficient manner. If it's in your apartment building and just walking up another hallway, if it's possible, and doing some stairs. So those are just simple things to incorporate. Okay. All right. So we talked about some dosing, how much exercise and how often. Those are really hard questions to answer, for me to answer when I see patients, because I don't know how you do on a regular basis. So what I usually start with is to ask everybody to do it at least 2 to 3 times a week, whatever can work in between in your schedule. Start with 10 minutes a day, and then work up to 30 minutes if it's possible. And we're talking about aerobic exercise, the one that Dr. Riazi talked about. So that's the one that's going to work your heart and lungs. Then you want to also, then if you can do this on a regular basis, then you add strengthening. And strengthening exercise is just resistance, but not with weights. I'm a big believer in those resistance bands. I'm not a big believer in weights. The other thing is body weight supported exercise. So even if you were to practice moving from one chair to another chair, you're working your arms, and that's exercise itself. Sit to stand. There's a bunch of other ways to work on body weight supported exercises. So that would be a way to include strengthening. I think that's my next slide. Oh, okay. All right. So stretching composes of exercise consists of 3: stretching, strengthening, and aerobics. So we talked about aerobics. I talked briefly about strengthening, and stretching is making sure that you're flexible, and we don't have to be doing yoga classes or anything, but as long as you're moving your body in order to stretch all the muscles in a way that you will remain flexible. And again, if you have a good therapist, they can help you work on those. How to stay safe: wear appropriate clothing, taking your heart rate before and after, monitor your temperature, warm up before you exercise. You've heard people say it's important to warm up, and the reason why you want to warm up is to get your body moving and getting ready to exercise. You want to stretch after. There used to be a time when we used to stretch before, but we're moving away from that because you don't want to stretch a muscle when it's not properly warmed up. And then the other thing that we talked about is incorporating balance exercises. And that can be in the form of single limb stands, just doing step-ups on a stair. There's many other ways to work on balance. I know I'm being very brief and but that's something that needs to be discussed with your therapist, because I don't want to just hand out recommendations without seeing the patient. So, and then lastly, use ice if needed. Cody talked about doing an ice bath before he would exercise if he knew that he was going to do a big bout of exercise, and those, again, we could talk about that. Oh, stretching, strengthening, aerobic. Here we go. I knew I had a slide. So Tai Chi is another form of exercise. Stretching, and then traditional exercise. Strengthening using resistance or body weight. Again, like I said, the resistance bands are really important. And the reason why I'm not a big fan of weights is because if you have a resistance band, and let's say you're having a little bad day today, then you can change your location. You can move a little bit closer to the stabilized place, and then you're not pulling so much and you're not working your muscles so hard. But if you had a 30-pound weight, the 30-pound weight is always going to stay 30-pound weight, and you might hurt yourself in that point. So there's always way to incorporate resistance bands into your program, and then you can travel with it. That's the other thing. I saw somebody back there. And aerobic, anything that you enjoy: swimming, dancing, walking. The idea is to increase your heart rate. All right. Exercise recovery. So the one question that I always get asked is, how much do I exercise? Again, my answer is, I don't know how to tell you this, but what I will tell you is that whatever you did today, and if tomorrow you are flat in bed and I can't do anything more, then you did too much today. So when you are starting your exercise journey, be very slow and methodical and record everything so that when you, supposing you, like, I don't know, you go out for a walk, you went to see that yellow bridge over in Pittsburgh, and then tomorrow you just can't move anymore, and you're just like, I just am tired, then you know that that walk was too much. So you need to make sure to see your recovery. That's really important because there's a delay in the lactic acid buildup, so and that'll show up the next day. So that's what's important. So if the next day you're fine, then you know that whatever you did today was enough, that you can maybe push yourself a little bit more, and then see how you do the next. And whenever I say push yourself, whatever you're doing, I only tell everybody to increase it by 5%. So if you walked 100 steps, then go 105 a week later, and then another 5% after that. So whenever I build a program, I make them do it for a whole week, and then build up 5% the next week. Okay, I feel like I've taken over.
No, it's okay.
The benefits of an adapted sport, team sport, is you have the camaraderie. It's you have teamwork. You have someone to kind of, I guess, complain about, like, oh, I can't do this, but then they can kind of collaborate with you to tell you what you could do differently. So I am a big believer in team sports and adapted sports. So if you're able to, I would say that try to do that. Special Olympics in the U.S. is really big. And then usually in your local area, you can find organizations that will have some kind of adapted sports.
And for parents of children, what I learned from them is that bringing your child to a place where adapted sport takes place is also support for you, because you will meet other parents, and it's often a very strong peer group which offers support.
And I don't know how many more slides I have left. Okay, so this is in the Pittsburgh area. These are all the adaptive sports. I know probably all of you are not from the Pittsburgh area, but this is what I came up with and I Googled. The other thing that I wanted to say, that I am a practicing physical therapist, but I have learned that my job is to make you independent, that you don't need me anymore. And if I am not able to do that, if I have you keep coming to me, then I'm not doing my job. And that's exactly, the goal of physical therapy is to get you independent to doing whatever your exercise. Yes, if you had a little setback and you need to come back, that's fine. But if I have you coming 3 days a week for me to watch you do your exercises, I'm not a good therapist. And that's really important. So that's what you need to make sure. Maybe once a month or once a week to make sure you're doing it properly, that's fine. But if you have to go repeatedly to your therapy, that's not a good therapist. Unless you're pediatrics, then they have intensive therapy. That's a different issue. So just remember that if you have someone that's making you come in repeatedly, find another therapist.
Well, in the Netherlands, that situation is different because many physical therapists have a gym, and then people are allowed to go there at that gym, and some of them prefer to go there rather than to a regular gym because they're not comparing themselves with people without a neuromuscular condition. And then the physical therapy practice is in fact the place where you do your own exercise, and the physical therapist is available somewhere if you have a question.
I wish they had that over here.
Mm-hmm. It's paid for by the insurance if you have a neuromuscular condition also. So come to the Netherlands.
Okay. All right. That's all we had. Any questions? No questions? Okay.
Thanks, guys. You might not be able to share too many details of the NAC trial. I'm just wondering, for those with RYR1 who started NAC in the trial, was there a specific exercise battery they did for a period of time, or did they just go away, then come back and get remeasured?
So no, we didn't give any exercise because everybody's coming from a different place in terms of their abilities, and it's very hard. That is one of the hardest things to do is exercise trials. And I know there's a huge gap in the physical therapy literature in terms of exercise, but it's having been in research for 30 years and as a physical therapist, it is really, really hard to prescribe exercise. There's been trials where they're like, you exercise at 50% of your max, or you do this. It's still really hard to keep people motivated to do it, because then you ask them to do it a certain number of times a week, and it's very challenging. So to answer your question, no, we didn't have anybody. We just gave them a NAC, saw them 6 months later, and then they did whatever they did. We did a very good inventory in terms of what their activity level was beforehand, and then I guess we would check afterwards. So yeah.
But I think it's a very important question in this disease group, not specifically for malignant hyperthermia, but I'm thinking back of the UNITE-CNM trial in centronuclear myopathies. In the Netherlands, I was the PI of that study. There were no recommendations in the trial protocol about physical activity. And one of the patients who was planning to start, it had to be postponed because it was March 2020, it was the outbreak of COVID. He got scared because he had reduced vital capacity, reduced muscle strength of respiratory muscles, so he started training. And over the course of 3 years, he was able to increase his walking distance from 700 meters to 12 kilometers by doing physical exercise in the local community and exercising, training himself. The trial stopped because of safety reasons, but if he had done this during the trial, the interpretation of data would have very difficult because it would not have been noted. Everyone would think, well, it's a wonderful effect of this study drug, whereas it was maybe partly or even completely the effect of the study drug. So now I talk to each sponsor of trials to make sure that you include in the trial protocol that patients remain on the same level of physical activity throughout the trial, because it can have a big impact. And it's not that everyone is increasing his strength and walking distance by 1,000% by starting to train, but he had not trained in puberty. He was growing older, different circumstances, and then finally thought, well, I can have influence on my functional abilities and I'm going to train. And for him it worked very well, but it's a very, very, very important point.
Guys, you spoke, second question, sorry. You spoke about people with RYR1 having difficulty to aerobically metabolize, and we do go into anaerobic metabolism more easily. Sheila, do you have the level of detail, like why that might be? Do we traditionally have less mitochondria? Is calcium leak toxic to mitochondria? Like what do you think the theory is behind that?
Very good question. That's why. So we have bits and pieces of data. So that's what we observed from the MR spectroscopy. Then with the metabolomics studies that we've done, we noticed that the Krebs cycle is not really utilized well by RYR1 patients. What they do is they use their fatty acid oxidation to produce ATP. And 36 versus 2 ATP. So fatty acid is basically an inefficient way of producing energies. Now, then at some point, you have a problem with that pathway, and there's a problem with the accumulation of fatty acid. But I'm not going to go through that. Back to the mitochondria. So this is what we observed. Then a group in UK, that their MH center in UK, they actually pin it down to complex 2 of the oxidative phosphorylation pathway in the mitochondria, that we believe it's secondarily affected by, back to your observation or what you mentioned about calcium. So we think this is the hypothesis. It has not been proven, but this is the hypothesis that the calcium accumulation, the calcium leakiness, goes to the mitochondria. Accumulation in the mitochondria secondarily affects the complex 2, which affects the oxidative phosphorylation and aerobic pathway.
I think one of the... Okay, go ahead, sir. Go.
Sorry, I just had a question. Like, do you have any advice on how to encourage our family members to start exercising who maybe that's not something, or how to find an exercise that works for them when that's not something that they're used to doing, like getting people to start making it a priority in their life when they're very new to it?
So turning a couch potato into an exerciser. Yeah, that's like the question of the day. I don't have an answer in terms of how to do that. I think it is really hard if someone doesn't have. So let me back up a little bit. When I was working with a population of children, and I would have to see these kids in the inpatient side of the hospital and get them up and moving and riding their tricycle and all that, just to get them moving. And then I had one PI says to me, he goes, just make a move. And I'm like, I can't lift a person physically onto the bike and have them pedal, or I can't drag somebody down the hallway to walk. So then his response back to me is, well, that's what you're here for, so figure out another way. So we figured out another way. We got the Wii. We started out slowly with just playing with the Wii, regular Wii, and then we moved to a program where they have to get up and move, and so it took a while before I figured out that this child liked to do that dance. I think it's called dance. It was some kind of dance Wii game, but it took a while. It took about 2 months to get to that point, and a lot of times in these centers you don't have 2 months. So I don't have an answer to you. I'm sorry. But basically it is, even if it's just, come with me, let me go to the mall. Come with me, let's go to Walmart. Come with me, let's go to Costco. Something that you're up and moving. And then, as Dr. Borman said, park far away so that they have to walk. So just increasing things, making it challenging for that person to be a couch potato. Like, just let's get up and do this kind of stuff. So, yeah.
Another thing I often tell patients, well, and also can tell you now, it's now a physical therapist, a neurologist, and an anesthesiologist here explaining about the advantages of physical activity and exercise. It could also be a general practitioner, an psychiatrist, a pulmonologist, a cardiologist, an orthopedic specialist. So any doctor would give the same message. So it's not for your muscles only, it's for your health in total, and you can invest in it now, and you will have the benefits throughout your life. And generally, when you do it gradually, there are hardly any side effects, and that's very unusual in prescribed drugs, for example.
So the other thing that I always try to, in your medical journey, what is going on in your lives, you may not have control over the progression of a disease. You don't have control over the medications you have to take. You don't have control of whatever's going to happen in terms of any kind of crises that you may occur. But the thing that I remind everybody is this is the one thing that you have control over. This is the only thing that I can't make you do because I can't physically move. And if I do range of motion, if I come in and I'm like, okay, we're going to move your arm, the only one that's getting stronger is me, not you. So it is really, really, so I keep reminding everybody, this is the only thing that you can control. So if you have to come to a point in your life that, yes, I'm going to take control of this. And the fact that you all are here tells me that you are ready to take control of your lives. So it is then, so that's the thing, is that the fact that you're all here at this conference. I have had some patients that, the parents dragged the kids over and they couldn't care less, so, yeah.
And one thing to add to that, and I often also ask why someone is not wanting to do physical activity, and often in neuromuscular conditions, and I'm also working with people with McArdle disease, which is associated with recurrent episodes of rhabdomyolysis. These children could never run as a child. They were often considered to be lazy. It's autosomal recessive, there's no one in the family, it's not recognized, you don't see anything, they have normal muscle strength, but they just can't use some of their fuels in the body. And then they were often, gymnastics was traumatic. If they were told by their parents, or they had the feeling that their parents thought they were lazy, they never found a sport they really could compete in with peers. And these are reasons why people start disliking physical activity in sports, and you can talk about it and investigate it, assess it, and try to find solutions for that. And that might help, because just saying you need to sport where someone has all these experiences in childhood won't work.
So I just want to add a comment. I'm a nurse practitioner at an internist office, so I do primary care. And so I see a lot of patients that come in and, you know, they have a history, maybe they're older, and they'll say, you know, older, I hate to say that, but, you know, I'm 52, right? So they'll say things like, well, I have a family history of diabetes and obesity and high blood pressure, and that's just going to be me. And I don't say this just the first time I meet them, but I'll tell them what part is true genetic family history versus poor learned lifestyle habits. And I'll throw myself under the bus. I'm Irish and Italian, and I've never met a carbohydrate I didn't love, potatoes or pasta, right? So my poor learned lifestyle habit comes from my Italian side. So you don't like what I made? You eat more, right? So, you know, it's kind of teasing out what is been put generations forward and kind of working with that, because once you try to go against what they believe here, you're not going to make any progress. So I don't know if that helps, but I slowly ease that into, okay, well, what, you know, you can still have your pasta, but let's not have the whole platter, you know, really measure out a cup. And then, okay, if you're going to have an extra cup, then what activity can you do to offset, you know, we reward ourselves in life with food. Someone gets married, we have a party. Somebody dies, we bring food, right? So, like, change that reward system for them. Does that maybe help a little?
But also, I agree with, that is a great way to introduce that, but I also agree with Dr. Gorman in terms of you need to find out why. I had a physiatrist that I work with, and we both agree that swimming is the best exercise for anybody. And we push, go to the pool if you have a chance, you know, that kind of thing. And I had one young woman who refused. The physiatrist walked out of the room, and then I asked her, I said, what's really going on? She goes, I don't want to wear a bathing suit. So then all of her options to go to a pool required to go to in a public space. They didn't have a pool at their backyard, so they could, you know. So then after that, I told the physiatrist, I said, we need to lay off on that pool. She's not going to go. And then he kept pushing and pushing. I'm like, we're not going to push the pool. We have to figure out another way. So we figured out another way to do that. So it is asking a lot. It does take time. And if you're in a PT clinic and you are told that you have 30 minutes to do X, Y, Z, you may not have the time to figure that out. But hopefully over time, it is, again, the job of the physical therapist to figure that out to help you with that. So.
And as an adult neurologist, I do diagnose patients with a congenital myopathy and also rare one-related myopathies in adulthood. And then I tell them, so whenever we have to diagnose, so now you need some time to reset yourself, to understand what happened in the past, what was related to this, what was very beneficial for you, what was not beneficial, and you want to change. And it will take a few years until you get to know your body with this knowledge now. And it won't be already next year. Take your time for it. Find the ways you can do it, but it's not something which will change immediately once you have a diagnosis.
Thank you so much. You guys were really motivating. I think what's hard too is that whatever our psychological issues are that keep us from liking exercise or believing that it's going to help or making excuses and not sticking with it, whatever our issues are, I do think it's probably not fair that, you know, that because some of us don't do enough to maintain our strength, you know, like I just got really mad at my daughter on a trip because, you know, I needed her to help pull me up really steep inclines getting off a cruise ship onto the docks. And there was just lots of instances traveling where I like relied on her really heavily in a way I haven't in the past. And, you know, I think it's a catch-22 between like how much should she help and support me physically in terms of doing things for me or with me when we're together that, you know, had I or do I do more for myself, I wouldn't need to rely on her as much. Do you know what I mean? So I think it's hard for our loved ones to know when are we like enabling them sort of or doing too much. And do you know what I'm saying? Like I think it's a catch-22.
I completely agree.
I apologize, Mairead.
No, I completely agree with what you're saying is that you know, everybody's personality is different, and we all have to kind of work within the personality of that person. The only thing that I would say is the person, if you know you have this, you know, possibly progressive issue in terms of weakness, there will be a time when, and again, I brought this up in the scientific meeting, I found the most important thing that drives somebody to do the exercises that are told is pain. If you have pain, you're going to do it. Mm-hmm. And secondly, is that eventually to maintain your independence, to walk, to go to the bathroom, and come back. Mm-hmm. So if you can't do those two things, if you can't be pain-free or can't do that, there's really no motivator. So there will be a time when you will need help to go to the bathroom, but if you can delay that, then you're better for that. So, I mean, I hate to be crude about that, but that's pretty much, that's kind of, having been in this profession for almost 40 years, I have, over the years, that's what I found. Basically, break it down to pain, and can I walk to the bathroom? Because it is, so.
Thank you. Maybe 2 or 3 years from now, I'll be different. And I can be the example that you've helped change me in that way.
Walk around Costco. All right, I think we're done. Thank you. If you have any questions, you can grab us.